classroom. We will proceed with the lectures in series. We'll try not to skip any more. At present, Nayeli Ayala, who is the downtown proctor for that class, is at 1604. She's taping one of the lectures for video stream right now, so we'll get her and Marco to assist with some of those. What I'd like to ask right now is if someone in the downtown lecture hall could touch their microphone so that we could see that you're there and we know that you're hearing us, please.
I can hear you.
Okay. When you touch the microphones, you need to press and hold, count to about 4 or 5, and then begin to speak. There's a delay between when you first touch it and when it will activate to let you speak. So all I heard was eep. So you do need to touch and delay a little bit. Could you do that again from downtown, please?
We can hear you fine.
Okay, thank you very much. You didn't come in on my monitor down here, so I'm not sure what's happening there, but as long as you're hearing us, we won't worry about it. So we'll switch now over to the desktop and begin the lecture on the female reproductive system and the menstrual cycle, and this is lecture number 4. So we've converted the slide presentation to a solid black background with white text. We're testing to see how that works for presentation. I have them all prepared in the opposite for posting on WebCT. Obviously, printers would run out of their ink very quickly if we had them printing in this format. So I keep forgetting to transform them to this. So any feedback that you want to provide to the WebCT mail as to whether this comes through easier through distance learning will be greatly appreciated. So we start first with a description of the secondary organs that provide the support of the gametes, and this is based upon figure 2.6 from the textbook. And of course, this includes the uterus, which has the different portions, the body, which is lined by the perimetrium, the outer lining, the myometrium, the middle layer, the smooth muscle layer, the endometrium, the inner layer, and then the cervix. We had seen this on a previous slide, and actually this is the same slide that we had seen previously. So within the abdominal cavity, abdominal pelvic cavity of the female is the internal reproductive structures. The ovary we've described in adequate detail, I think, to understand the anatomy, the functional anatomy of that structure. And we see the fallopian tube here with the parts that we had described before, and we will revisit that. Now, of course, the body of the uterus is seen here with the outermost lining that is continuous with the entire lining of the peritoneal cavity. This would be called the visceral peritoneum if you have taken the anatomy courses. The visceral peritoneum lines the organs, and the parietal peritoneum is that reflects off onto the body wall. So they are continuous layers that protect the organs. And when we see it on the surface of the uterus, it's called the, what was it called? The perimetrium. It's around the uterus, the perimetrium. And then the smooth muscle layer is the myometrium, and then the endometrium is, of course, a dynamic layer that undergoes tremendous change throughout the menstrual cycle. So we see those layers here. The perimetrium is where the vasculature is going to enter into the uterine wall and provide the arterial supply to all of the structures, of course, all of the tissues within it, but we see it forming the spiral arteries within the endometrium. We will discuss the histology of the endometrium in a bit more detail in just a moment. And I guess that moment has passed. So here we see now the different portions of the endometrium. The uterine lumen or cavity would be at the top, and the myometrium would be down here at the bottom of this slide. So the endometrium is this layer extending from this red to the pink zone, and we follow the arterial branches coming in. There's an arching branch, arcuate artery, and then a radial branch. There's a straight artery that comes into the basal layer of the endometrium. This is the layer of the endometrium that will never slough off during the menstrual phase of the menstrual cycle. This is also the reserve cell layer, so these cells have tremendous mitotic capacity because they will proliferate to replace the functional layer at the appropriate stage and with the appropriate stimulus from the, of course, it's primarily estrogen that is stimulating that. As we approach the luminal, the AD luminal, remember that term, ad luminal, portion of the functional layer, we see the vascular venous spaces, the lakes, are forming at this level. So implantation is going to occur on the epithelial lining of the endometrium, and the cells of the blastomere, the blastocyst, will begin to infiltrate through those, between those, and insinuate itself into this area, this rich vascular area. And again, we think always of diffusion being the primary source of nutrients coming into the developing zygote and embryo. So it has to, as it's growing larger and larger, the zygote has to approximate a vascular supply to establish the hemochorionic connection. So we see the spiral arteries. These are very important for understanding the mechanisms by which the menses is initiated. They actually will undergo contractions, and the smooth muscle will close off these spiral arteries and cause an ischemia, an intense ischemia, a complete loss of arterial blood supply to the functional layer, and this is what actually triggers the sloughing of the functional layer of the endometrium. So this histological understanding of the blood supply to the endometrium is very important. Of course, what isn't shown here is the venous drainage that parallels this, although there isn't a spiral vein, but similar type of venous structures occur. Another component of the endometrium is the glandular portion. So in the basal layer, there is the primordium, the collection of reserve cells of these glands, and they have the capabilities of regenerating this long duct that reaches the surface of the uterine cavity. So this also has to proliferate and recover. What's not being shown are other parenchymal cells, the decidual cells of the endometrium, and we'll talk about those a bit later when we talk about implantation and the things that occur there. So there are many other cells within that zone, decidual cells, that are very important. They store a tremendous amount of lipids and carbohydrates, and they will undergo a reaction where they will autolyse and make those nutrients available to the implanted zygote and embryo. So continuing with this discussion then, the uterine tubes, other terms for this, the salpinx. So salpingitis is inflammation of the fallopian tubes, which is the most common term we hear. Oviduct is another term for these. So a series of terms, all synonymous for the same structures. And we had identified the different parts. The intramural portion was where it goes through the wall of the uterus. That's the most narrow portion of it. Then, the isthmus is the next portion, the arching portion, Then there's a dilation, the ampulla, where the implantation typically occurs. Yeah, see that here. So this is the site of fertilization. And then the outermost portion is dilated, funnel-shaped. It's called the infundibulum. And this has the finger-like projections that will pick up the ovulated ovum. And the remainder of the tube is the conduit for the ova to reach the uterine cavity. If there is fertilization, then the zygote will be carried through the lumen of the uterine tubes as it is undergoing cleavage to reach the uterine cavity for implantation. So here then we see the uterine tube and all the different parts of the uterus as well. The body is this main part. The portion that projects above is called the fundus. The horn of the uterus is where we see the intramural, inside the wall, portion of the fallopian tube. This is very important to understand because ectopic pregnancies, implantations that occur other than in the uterine cavity, if they occur here and rupture this, there is a tremendous risk of hemorrhage and possibly loss of life of the female. So there's the body portion that has these components that we mentioned. The isthmus portion of the uterus is where we find the cervix and the junction with the cervix, and then this is the isthmus, the narrow portion of the fallopian tube. As I said, the intramural portion is actually the narrowest, and it is continues into the narrow portion, the isthmus, opens into the ampulla, and then the infundibulum with the fimbria. And these fimbria will, of course, find the mature Graafian follicle that is bulging at the surface of the ovary and will surround it and guide the ovulated ovum into the ampulla, awaiting fertilization. So in this slide, we see a histological sample of the epithelial lining of the fallopian tube. So the connective tissue holding the cells in place is down here, the basement membrane. This is a capillary with some blood cells, red blood cells in it. And then this is the surface, the lumen of the fallopian tube, and we see these long cilia on these simple columnar epithelial cells. So these cells that are highlighted have cilia on their surface, and when those cilia move, they will be moving fluid from the peritoneal cavity, from the infundibulum, toward the uterus. So fluid, if it was moving in this direction, would be moving toward the uterine cavity. So this guides the movement of the ovum, and if it is fertilized, the zygote to the uterine cavity. It creates a direction of flow opposing the movement of the sperm, and of course it creates a situation where the sperm that can swim the farthest and the longest and all of that are more likely to to reach the ovum and have a chance for fertilization. I would need to increase the size of this text, as I can see, but I'll read it for you. The highlighted cells aid in the movement of the ovum. We said that is correct. They do not provide nutrients to the ovum, and they are secretory cells of this epithelium. That is not true, and they do not release estrogen and progesterone. They have cilia on their surface that aid in the movement of the ovum through the fallopian tube. I don't know if you can hear the rain and the thunder from here, but we're getting it good now. The primary organs then are the site of gamete development, the ovaries, and they produce the gametes and the reproductive hormones. So here then we can talk about the female cycle, and this is not my most extensive lecture on the menstrual cycle, but it will suffice to give us an understanding of the primary features of this complex neuroendocrine axis. So the pituitary gland is a key component. It is the source of the hormones called the gonadotropins. The gonadotropins are follicle-stimulating hormone and luteinizing hormone. Of course, the acronyms for those are FSH and LH. So FSH will stimulate the recruitment and the development of the follicles, as we had mentioned in the lecture on gametogenesis. So we can picture that now. Many primary follicles where the follicular cells are just a thin layer. They will be targeted by FSH, those follicular cells, and undergo mitosis and undergo a tremendous increase in metabolic activity. So a lot of enzyme genes will be expressed to build up the cytoplasm and perform the function that they perform to contribute to the estrogen synthesis. So the FSH will recruit and develop the follicles. LH targets the luteal cells and the follicular cells. Actually, it's really the thecal cells, and stimulates the enzymes involved in the synthesis of estrogen. The LH, of course, is also involved in triggering ovulation, and we'll see that on a graphical display of the endocrine cycle in just a moment. So within the ovaries are the primordial follicles that will be recruited as primary follicles and then develop to the secondary follicles, the mature Graafian follicles, as we had said, and the estrogen will be synthesized by the follicular cells in response to be more accurate, the LH. But both will actually contribute in a rather complex way. So let's just generalize it and say both the gonadotropins contribute to the estrogen synthesis. So ovulation will occur in response to an LH surge. So there's a series of events early in the menstrual cycle that lead up to a switch from a negative feedback to a positive feedback of estrogen, and there will be a surge in the amount of LH that is released into the plasma, and this peak in the LH, the surge, will trigger several molecular events at the Graafian follicle, leading to the activation of the degradative enzymes that will break down the connective tissue and weaken the barrier between the Lec4 folliculae, that liquid that's within the antrum of the follicle, the mature follicle, so that when we get an increased in pressure within it, you're likely to have it rupture and to bring about ovulation. After the LH surge and ovulation, the remaining follicular cells will go on to differentiate into the corpus luteum, and what they will do is they store a tremendous amount of cholesterol ester, and cholesterol ester will stay within the cell. It is a lipid, but it cannot diffuse out of the cell. So it's stored in the cells of the corpus luteum, and that gives it the yellow color. So luteum means yellow and corpus means body. So the yellow body is yellow because of the stored cholesterol ester, and that is the source of the precursor for the production of the gonadal steroids. So they will switch gears and produce primarily progesterone. Up until now, the follicular cells were producing mostly estrogen with some progesterone. Now they're switching to produce mostly progesterone, but still some estrogen. the degeneration of the corpus luteum is prevented by human chorionic gonadotropin that's secreted by the cells surrounding the blastocyst. They're called trophoblast cells that will develop into the chorion, a portion of the placenta. So if there is not fertilization, the corpus luteum will basically self-destruct within 14 days, because the tremendous amount of progesterone that it produces now is creating a potent negative feedback on the anterior pituitary. And so what happens here is that the pregnancy becomes independent of the maternal pituitary gland and is under the control of the developing zygote, ultimately embryo, and then fetus. And then finally, the placenta of the fetus will even be the source of the progesterone and estrogen and all the hormones necessary to continue and even to contribute to the termination of the pregnancy, in other words, inducing labor. So it remains functional for the 20 weeks of pregnancy, degenerates 10 to 12 days. Actually, it's quite close to 14 days in humans after ovulation if there is no fertilization. Ultimately, this corpus luteum will become a scar tissue and will fill with collagen, the white connective tissue, and it's called the corpus albicans. So the corpus luteum becomes the corpus albicans. So here we see this neuroendocrine axis in this illustration. So the hypothalamus is shown here above at the base of the brain, the pituitary stalk, and both the anterior and the posterior pituitary. The anterior pituitary is the structure of interest, and there are neurons in the hypothalamus that synthesize and secrete gonadotropin-releasing hormone, or GnRH. It's one of those releasing hormones from the pituitary, and it prods the pituitary, or stimulates the pituitary cells in the anterior lobe to secrete FSH and LH, actually to synthesize and to secrete. You've got to synthesize to replace what you have secreted. It's a very important biological concept to keep in mind, especially relevant to endocrinology. The gonadotropins are released into the blood, and they target the ovary, where the FSH and LH stimulate the egg maturation and estrogen production and other events. So we are generalizing, and we are allowing that for now. So the blood level of estrogen will rise throughout the menstrual cycle, especially before ovulation, and it will stimulate the surge in the LH secretion, and that switches the typical negative feedback of estrogen to a positive feedback that we see here, and will cause this buildup and storage of LH, and then suddenly inside the pituitary cells, and then suddenly they will react to the high estrogen and the GnRH that will be released, and they just dump all of that in just a matter of hours to produce this sustained, very high level of LH in the blood, the LH surge. The LH surge will stimulate the mature Graafian follicle, causing the release of the egg or the ovum, and triggering the formation of the glandular structure, the corpus luteum, that will go on to develop the yellowish coloration and synthesize very high levels of progesterone and estrogen. Remember, these are lipid-soluble, so as soon as they're synthesized, they diffuse away. So that's why you have to have the cholesterol ester, giving it the yellow color, stored so it doesn't diffuse away. As soon as the enzymes act on that and produce the progesterone and estrogen, those lipid-soluble molecules diffuse away into the blood and are carried off by the hormone transport proteins in the blood. So the rising blood levels of the progesterone and estrogen then will begin to have a potent negative or inhibitory feedback, and it will inhibit at the pituitary the LH and FSH synthesis and secretion, in the last phase of the menstrual cycle, so that if there is not a pregnancy, that menstrual cycle is terminated, and the menses is the terminal, actually the first day of menstrual flow is the indicator of the first day of the next menstrual cycle. So this illustration shows us this again. We see the blue arrow is stimulatory, so that's our positive feedback. We should follow the G and RH in these first for the stimulatory, and then the inhibitory, the typical negative feedback that we think of at the pituitary and the hypothalamus. So if we start at step 1 again, to go through this one more time, G and RH from the hypothalamus triggers synthesis and release of the gonadotropins FSH and LH. The FSH contributes to the recruitment and development of the follicles. We're only following the one that matures to the Graafian follicle, but we know several others are recruited and contribute to the estrogen levels that will increase slightly at first and then get very high and trigger the switch from a negative to a positive feedback to bring about the LH surge number 5 here. So the FSH is the recruitment and development of the follicles, LH and FSH contributing to the synthesis and secretion of estrogen to the point where there's many follicles and many follicular cells. So there's this tremendous synthesis and release of estrogen that triggers molecular changes in the hypothalamus and the pituitary such that we now have a positive feedback, and that will bring about the LH surge. There's also an FSH surge, but that is not as significant and important as the LH surge. The LH surge will trigger the events that bring about the actual ovulation and the transition to the corpus luteum for the final sustained high progesterone and estrogen levels that will be sustained if there's a pregnancy and human chorionic gonadotropin comes in to replace the pituitary, the maternal pituitary gonadotropins. So to put it into perspective, the oral contraceptive pill is taken early in the menstrual cycle, and what it does is it will prevent increasing levels of FSH and LH early on, prevent recruitment and development of follicles, prevent the elevated and ultimately the high estrogen. By preventing those, we prevent the positive feedback. By preventing the positive feedback, we prevent the LH surge. By preventing the LH surge, even if there was a follicle recruited to reach maturity, it would not get the LH surge to ovulate. So in effect, then, the ultimate endpoint of the oral contraceptive pill is that it blocks ovulation. So ovulation should not occur. And in this way, there is never a chance for the gametes to unite, so it is a true contraceptive. It works against conception, so contraceptive means against conception. So the oral contraceptive pill, through that mechanism, prevents ovulation and is a true contraceptive. Now we can look at this in a bit more detail. Again, GnRH with the two gonadotropins. The FSH triggering the follicular cells and the granulosa cells. The LH targeting follicular cells, but the thecal cells differently. The thecal cells will be stimulated by LH to synthesize and secrete androgens, actually testosterone, that then diffuses over to the granulosa cells nearby, which under the stimulus of FSH will convert the testosterone to estrogens, and it is the estrogens that are involved in the negative feedback. So in the early to the mid-follicular phase, the first part when the follicles are being recruited and developed, so I refer to this part, collectively as the pre-ovulatory phase of the menstrual cycle. These are the events before ovulation. So the ovarian cycle starts with follicular phase because we have recruitment and development of the follicles. So in the early to mid-follicular phase before ovulation, this is what we are seeing. The estrogen levels will be rather low, so we can go to the profile down here. So we're looking at the this purple portion here where the estrogen and progesterone levels estrogen and progesterone levels are low, so the gonadotropins are going to be a bit higher, and they're going to recruit the development of the follicles. And one of them would mature for ovulation, which we see is really the event. So this shows that earlier part much better. So the estrogen progesterone levels are low, so the FSH and LH will be higher or increasing, and this will recruit and promote development of the follicles. Again, we are just following the one that becomes the mature Graafian follicle. So that's the early to mid follicular phase shown in the previous slide. The late portion shown here in green is when the levels of estrogen will be much higher. There will be small amounts of progesterone, and collectively they contribute to the switch from negative to positive feedback, so that a tremendous amount of LH and FSH will be released, and there will be the surge in the LH and FSH that will act at the ovum to trigger the events, the collagenases and things like that, to break down the connective tissue, so that there will be, and to cause an increase in the intra-follicular pressure to cause the rupture, in other words, ovulation. So ovulation occurs at the end of the follicular phase. After the follicular phase, it's going to be the luteal phase, because the corpus luteum now is the primary structure present, and we see that here. There is an almost immediate reversal from positive to negative feedback. So we are in positive feedback in this portion here, producing the LH and the FSH surge. Immediately after ovulation, there's a switch back to negative feedback. So as the progesterone and estrogen levels will begin to increase, they are going to produce a potent negative feedback and bring the gonadotropin levels down very low. They're still high enough to maintain the corpus luteum until way out here in the late luteal phase. So in the early to the mid-luteal phase, we're seeing the switch back to negative feedback, a decrease in FSH and LH, and we see that it's precipitous at first and then it's gradual thereafter. These lower levels of FSH and LH are still sufficient to trigger the change of the corpus luteum, so that it now is synthesized and secreting progesterone and estrogen. There's also this inhibin that acts directly as a negative feedback on FSH. We're leaving it out of the story at this time. And then the late luteal phase is when the gonadotropins are very low, too low to sustain the corpus luteum, so progesterone and estrogen levels drop to very low levels, levels below which the spiral arteries become non-functional, or at that border. So we've now fallen below the levels where the spiral arteries now undergo a spasmic contraction until they really just, the smooth muscle just constricts completely, and there's no blood flow passing beyond that spiral artery in the basal layer of the endometrium. So the functional layer is going to be sloughed off. And this is, again, the point when menses will begin. So it's the end of the prior menstrual cycle and the beginning of the next one. In individuals that are taking the oral contraceptive pill, of course, there's that Sunday that you stop taking, and it triggers this same event. Suddenly, progesterone and estrogen levels drop below that critical level. Spiral arteries contract, and for the next week, the individual will not take the oral contraceptive pill or the sugar pill that's in the container, and the menstrual phase is induced, and then the following Sunday they begin taking it again and create slightly higher levels of estrogen and progesterone, and exploit the sensitive negative feedback to prevent everything that we just described. So this slide is a histological sample of a structure in the human ovary. Looks very big with the stromal cells, some primary follicles out here that have not been recruited yet. The surface epithelium in this area looks like there's a little bit of scarring at the surface near here, and there's just this central portion where it looks like there's something going on, and then these columns of cells that are ruffled and crumpled, and it's all yellow. So this obviously is the corpus luteum, and the major hormone produced by this yellow highlighted structure is obviously progesterone. So which of the following phases or processes of the monthly reproductive cycle of the female occur simultaneously? The maximal LH secretion and menstruation? No. The maximal secretion accompanies ovulation. Maximal steroid secretion by the corpus luteum and menstruation? No. Minimal secretion of steroids by the corpus luteum is what triggers menstruation. Early follicular development and the secretory phase of the uterus. We did not describe the phases of the uterine cycle, but obviously the first part of the menstrual cycle is the menstrual phase of the uterine cycle, because this is when menses is occurring. We said the first day of the cycle, of a new cycle, is the first day of the external presentation of the menstrual flow. So that represents day one of a new menstrual cycle. So the first part of the menstrual cycle for the uterine cycle is the menstrual phase. The next phase is when that is growing back, and we see the proliferation of the basal layer. So the proliferative phase, it corresponds to the middle to late follicular or preovulatory phase for the uterine cycle, then ovulation, and then after that, the progesterone triggers the glands of the endometrium that developed in the proliferative phase before ovulation. After ovulation, corpus luteum, the luteal phase, high progesterone. Progesterone triggers the secretion of the glands onto the surface of the uterine lining, the endometrium. So this is called the secretory phase. So the secretory phase is not associated with early follicular development. The regression of the corpus luteum and a decrease in ovarian progesterone secretion is obviously the two events that do occur simultaneously. In the late part of the secretory phase, or if we're referring to ovarian events, the late part of the luteal phase of the menstrual cycle, or the ovarian cycle, the corpus luteum is undergoing that suicidal event of producing the potent negative feedback, so it loses its gonadotropin support, so it will be regressing, and as it regresses, it, through negative feedback, eliminates the gonadotropin, so there is a decrease in the progesterone secretion. The oral contraceptive pill prevents blank and thereby blocks blank. So it prevents the LH surge through the mechanism we described. It's taken in the early part of the follicular phase, corresponding to the early, it's taken, initiated during the middle, approximately the middle of the follicular phase, the mid-follicular phase, which corresponds to the end of the menstrual phase of the uterine cycle. So at the end of menstruation, the oral contraceptive pill is initiated. So it will exploit the sensitive negative feedback, prevent FSH and LH release, so that we don't get follicular recruitment, we don't get follicular development, so we don't get estrogen levels increasing to produce high levels for positive feedback. So through that mechanism, we prevent the LH surge. That's really the big step one or goal of the oral contraceptive pill, prevents the LH surge. If we prevent the LH surge, we block ovulation. So now we can look more closely at the uterine cycle. It mirrors the cyclic production of estrogen progesterone by the ovarian follicles. Estrogen will trigger proliferation at the end of the menstrual phase of the uterine cycle. Progesterone after ovulation will trigger the secretion of the glands that proliferated earlier under the influence of estrogen. So the phases of the uterine cycle: menstrual, proliferative, secretory, and then there are a couple of others that are added to give a bit more detail: ischemic and pregnancy. So there are multiple phases of the uterine cycle throughout a reproductive adult female. The ones related to a menstrual cycle are A through D. Those, of course, related to pregnancy are A, B, and C, leading to E, but bypassing the D. Of course, after delivery, there's still an ischemic phase because we have to decrease the blood supply to the uterus so that there is no excessive bleeding or hemorrhage with delivery. So the menstrual is the loss of the part of the endometrial lining. Actually, it's the first 4 to 5 days, or it lasts 4 to 5 days. There should be an S at the end of this. So it's through the first 4 or 5 days of the uterine or the menstrual cycle, and has a duration of 4 to 5 days. So when it ends, we're at about the mid-follicular phase. So keep trying to go back to what's happening in the follicle, and remember that it's all pre-ovulatory for the menstrual cycle in general. And the proliferative follows the menstrual because we have lost the functional layer. Now the basal layer is being stimulated by the increasing estrogen levels in the mid-follicular phase, and those cells undergo tremendous mitotic division. The decidual cells, the vascular cells, and the glandular cells are all undergoing proliferation, and it is due solely to estrogen, rather high estrogen levels. So higher estrogen levels than what are produced by the oral contraceptive pill. So someone taking the oral contraceptive pill is taking a rather modest level of estrogen, exogenous estrogen. It's a derivative of estrogen, actually, a synthetic form. And the levels don't get high enough to produce a significant proliferation. There is adequate proliferation such that if someone does get pregnant on the pill, that you can sustain a pregnancy. But what it means is that an individual on the oral contraceptive pill is more likely to have a lighter flow during the menstrual phase because the degree of proliferation is blunted. versus an individual that is not taking the oral contraceptive pill. So by understanding the biological impact of the hormones, endogenous and exogenous, we can understand the reasons for these distinctions and the overt signs that the individuals experience. So the secretory phase occurs after ovulation, so it coincides with the corpus luteum controlled by progesterone. So it coincides to the luteal phase of the ovarian cycle. The proliferative is starts at the mid-follicular and goes to the late follicular, which ends at ovulation. The ischemic phase is the one we introduce. The decreased progesterone causes vasoconstriction and necrosis of the superficial or the functional layer of the endometrial lining. There is a drug, an oral contraceptive, actually it's an oral abortifacient that triggers this ischemia. It is RU486. Now that it is available in the United States legally, I'm not certain of what the name of it is on the container that you would receive, that individual would receive from the pharmacist, but the scientific term for it is RU486. It was developed as a corticosteroid antagonist, receptor antagonist blocker, and it happened to work very efficiently at the progesterone receptor. So regardless of the stage of the menstrual cycle, or the uterine cycle, if an individual consumes this progesterone receptor blocker, it triggers the ischemic phase of the uterine cycle. So there is a flushing of the endometrium. It triggers a menstrual flow. And thereby it is an abortifacient. If fertilization occurred, then actually there's no way of knowing for that individual when these are typically taken, this RU486 is typically taken, because it can be taken within the next morning or within a few days or a week or so of the coitus by the concerned individual, and it will trigger the same thing regardless. So typically it's taken before a pregnancy or a conception is confirmed, so since we never know, there's only one way to categorize it, and that is as an abortifacient. So this is what I was saying. It's important for us to learn in this class the information to make us responsible biology majors. So the distinction between abortifacient and contraceptive is that contraceptives prevent the gametes from getting together and prevents conception. So barrier methods like the condom and the diaphragm and the oral contraceptive pill are examples of that. And then abortifacients are like the IUD, the RU486. IUD is the intrauterine device, and things like that. And obviously true abortions, the surgical procedure. And then the pregnancy, of course, is maintained by the progesterone. So this question, how does the endometrium change during the menstrual cycle? The menstrual phase is the rupture of the blood vessels and the detachment of the functional layer of the endometrium. Then there's regeneration in the proliferative layer phase. We regenerate the functional layer, the decidual cells, the glandular cells, and the vascular cells. So that is the proliferative phase. And then the secretory phase described here, the secretory activity of the glands, the decidual reaction of the stromal cells, the formation of the coiled arteries within the endometrium, and the edema of the stroma. Then there will finally be regression, a temporary contraction of the coiled arteries, resulting in the ischemia of the endometrium. Without the blood supply, there will be the shedding. And then there is a consecutive dilation of vessels followed by a hyperemia of the endometrium. So there's a closure of the blood spiral arteries, and then an opening, and these two events will lead to the destruction and the sloughing off of the endometrium. So here we see the uterine cycle corresponding to the other events, early, the menstrual phase with the sloughing off up to about day 5, then the proliferative phase triggered by estrogen from the developing follicles, and then after ovulation, the secretory phase promoted by progesterone and estrogen with the ischemic phase just before the triggering of the next menstrual phase. So all of the following statements referring to the uterine cycle are true except FSH and LH directly promote development of the uterine endometrium, not directly. Estrogen is secreted from the developing follicle in the follicular phase of the cycle, that's true. Corpus luteum is formed from the ruptured follicle after ovulation, that is true. A fall in the levels of ovarian hormones signals menstruation, we talked about that as being true. So all of these are true, the second, the third, and the fourth, except this first one. So this slide is showing us different layers of the uterus. This is a histological sample, 5 millimeter scale bar. We see the parametrium, myometrium, highly vascularized, the myometrium extending all the way to the endometrium, the basal layer shown here, and the functional layer at the top. We go to a higher, different view of this, and we can see it. This is more like the proliferative, the secretory phase here. This would be more proliferative. You can see that the glands are not fully developed, but now they are fully developed at the surface, and there's a pale coloration of the stromal cells. So we would see in the previous one, this would be proliferative. This would be secretory phases of the uterine cycle. So these are the higher magnifications. You can see the ducts of the glands are just beginning to reach the surface. The stromal cells are still staining red. So this is proliferative phase. At the secretory phase, the ducts of the glands and the glands at the base are dilated, filled with the secretions, and the stromal cells have undergone a change in their appearance. They've actually undergone the decidual reaction to dump their stored sugars and lipids. So you should be able to distinguish those slides for the exam. This is the high magnification of the the secretory phase. The swelling of the glands indicates that. And this is the proliferative phase. So I appreciate your time and attention. The extra few minutes are helpful for us to complete this entire lecture series. We will begin with the next lecture on Monday. Everyone drive safely and have a good weekend.
Dr. Keeley.
Yes.
On the very last slide, one more time, the structures in the boxes that ask